everyone. Today we're going to be talking about the second visit of a prenatal workup for a pregnant patient who is O positive. So that means we don't need to do the RHIG workup for this patient or do any dosing calculations. This is strictly going to cover the testing of the antibody titer and seeing if there is a rise in antibody. So what we found out in the first prenatal visit was that the patient has an anti-Kel antibody. Okay, so that means, again, we're not in the RH grouping, so we're not worrying about anti-D. What we do need to do is, since we know that the patient has an anti-Kel antibody, we're going to be picking out a cell, a reagent cell from the antibody identification panel that is going to give us a Kel positive cell. And so I'm going to use the first one here because the other two that are positive for Kel, antigen-wise, are also positive for Chilano, and I don't want to do something that may be affected by dosage. So we are going to do reagent cell number 1 out of the antibody panel. So in order to do that, we need to pull this out. So whenever we use an antibody panel cell, I always just do this in the container so that you can do all of them at once. You want to make sure that there's nothing on the bottom, and then you'll know that the reagent cells are able to be used. So let's pick out number 1. Okay, so there is still a little bit there. We can resuspend this way gently. All right, and we'll continue to invert. All right, so that is the one we will use. Now, how do we set up the antibody titer? So you've done titers before, but it was with colored water, so that video has been out. But this one is different because it's not going to be very colorful, so it's not a visual representation of a titer. So we have the patient's first visit. We took off plasma and froze it for this visit today. We thawed it, and it will be the row in the back. So you can see all of them say 1 and then 1 to 2, 1 and 2, 1 and then 1 and 4. So that's showing that this was the first visit. Up front is the second visit here, the most recent visit, and it's following the same thing. It's 1 and 2, 1 and 4, 1 and 8. So we're doing a serial dilution, meaning that you have a consistent dilution factor in between each tubing. So I have set my pipette to be 500 microliters. So that's going to be 1/2 ml. And we're going to do that because we want to make sure that we have enough specimen to do the testing, but at the same time, you want to make sure that you can have a good enough amount to put against reagent cells and test them. Okay, so here we have first the titer that you need to do. And so we're going to use normal blood bank saline. Okay, I'm going to stick my pipette that I now have a tip on. I'm going to put it down into the saline. So I'm pressing down right here first. Down into the saline, make sure it's in there, and I'm going to pull up, and we're going to put saline into each of the tubes. Okay, same way, because remember, we're diluting out the specimen, so this is going to be a consistent dilution factor. So every time we go and pull some out of the previous one, it's going to keep being divided into half. So we will be looking at what reactions we get from challenging each of these diluted tubes contents against the reagent cell. All right, so I'm going to do this with both. The reason that we have the first visit also is because that's our baseline. We want to make sure, by the way, I do have throwaway tubes, they're set aside. But we're going to be running them in parallel to make sure that any differentiation from the first testing that was done is not due to clerical error or anything. So if we, you know, like QC, if you run it at the same time in the same way as the patient, you're making sure that your experiment is accurate. That's, you know, the scientific method. So same thing here. Okay, so I'll continue this off camera and then we'll get back. Okay, now I'm throwing my tip away and we're going to use a new tip. So this is a new tip, and I'm going to put a same amount that I put of saline in each tube. I'm going to put into the first tube and then pull out of that tube, put it into the next one, and continue to do that, because that is how you do a serial dilution. So here, making sure that it's not getting any bubbles in it, right? So we're going to put it in the first tube, and then we will resuspend gently. So at this point now, I have 1 ml of the dilution in there. I'm moving it over, so now this will have 1 ml. And since I'm going to continue to do, that same fashion, at the end we have the throwaway tube, so that the end result will continue to be at 0.5 ml. All right, so once we go through this, we're going to add the reagent red cells that we chose that are positive for Kell only. It's not heterozygous for Chilano also, so that means this is homozygous just for Kell. We will add those, incubate them at the 37 phase, and then we'll centrifuge them, read them, write down those reaction levels, and then we'll continue to the AHG phase. So I will only do this first line in front of you so that we won't waste a whole lot of video time. So I did my serial dilution up to 512, okay? And I'm going to put the end in the throwaway tube, all right? This, and I'm gonna get rid of this tip, right? I ejected it using the ejector button. All right, so I'm going to use a new tip, and I'm going to do the same thing with the first visit sample. This is the second visit sample, but I didn't want to put it in that line, so it's back here. All right, I'll get back to you. Okay, so I just did the first visit. I'm getting rid of that tip, and I'm going to put this away. If you look at all of these, they look pretty homogeneous with the level of fluid in them. Okay, so now what we're going to do is, this is where that reagent cell that we chose earlier comes in. Remember, it's homozygous. That's very important. So if you ever have an antibody that you're trying to work up in a prenatal workup, you need to make sure that it is going to be homozygous if that is a antibody that shows dosage. Okay, so the antigen representation is going to be homozygous on the reagent cell. Okay, so we're going to add a drop to each of the tubes. So we've got them here. We're not going to put a drop in the throwaway tube, okay? Because the throwaway is just if we need to go back and look at it later, we've got it. It's kind of like a safety. Using a lot of reagent cell. Okay. Okay, so now I have my dilutions all the way from straight to 512. All right, I'm gonna swirl them gently. And I'm not adding lists. I'm just going to swirl them and incubate them at 37. So putting them in. Trying to make it so you can see. Here we go. So swirl. I'm going to put patient's second visit together, and then I'll put the first visit together just to kind of make it a little bit easier maybe on myself. The reason we swirl them before we put them into the incubator is because the whole point of this is to try and give them the cells and the plasma and antibody. So the antibody in the plasma and the antigen on the reagent red cell. A lot of opportunity in order to interact and to form a complex if the antibody is present in high enough concentration. Okay, so present at all rather. Okay, so we're going to do 30 minutes on the clock. Come on. All right, so 30 minutes on the clock, and I'm not going to have you here this whole time, so I'll get back to you. One thing, again, you want to remember is check that manual thermometer in the back to make sure you truly are at 37. We are. I did press start, so the light is on showing that it is heating. All right, I'll be back. All right, so we ended our 30 minutes. Now we're going to swirl, put in the cell washer to go ahead and wash, and then we'll do the AHG phase. Right before that, though, we're going to do the centrifugation. So I'm just taking them out, swirling, putting them in the rack, and centrifuging them first. Okay. So let's see if we can get this up a little bit. All right. And I can do the first two of my first. All right, so that'll be like that. I'm going to write down spaces to do the reactions. So I'll be right back. All right, so that first bit was done. Whoops. And we can go ahead and read those. So I made a column, patient visit 1 and 2. So we're going to read them and then write them down. Sorry for the craziness here. It's on paper. Tripod trouble. Okay. So let's see. The first one we had. That's good. Well, it looked like a solid 4, but it's breaking apart. So this is visit number 2, and it looks like it's coming apart. Okay, so we'd probably say that a 2 or a 1. That was straight. And this is 2 and 4. 1 and 2, 1 and 4. So this is probably about, looks like a 1 in both of them. So with Kel, you may see a lower reactivity, or a reactivity at lower dilution factors, because this, I would say, is weak, if you look at that. And weak doesn't count, okay? So I don't know how well you can see that. So weak doesn't count. So weak started at 1 and 8. So that's tube number 4. So weak, and this was 2 plus 2 plus 1 plus. Actually, the first one was 2 plus. Second and third were 1 plus. Let's see the rest of what we have here. So they're looking weak also. So these two both are weak. So up to 64 is weak, but we're considering only 1 plus as being something that you would count. Man, it's hard to show it on the camera. Yeah, so 32 and 64. 1, 2, 3, 4, 5, 6, and 7 are weak. Looking at 8 and 9, which are 128. Those are looking negative. Sorry. Yeah, so we're starting negative at 1 and 128. So the last one should also be negative. I'm gonna look back. Oh, they're so weak. This one's weak too. All right, so I'm gonna take that back. Well, no, I'm gonna call that negative. All right, so those last three were negative, and then we've got the first two of the first visit. I'd call each of those a 1. You can't see it very well, but they look like ones. All right. So now I need to put the rest of the ones that we hadn't put into the centrifuge. So there's 4. And then we're gonna balance through the rotor with 4. All right, so then we'll read those. Come on. Okay. I just made sure the top was on a little bit better. All right, so that just ended, and we can get those out and start looking at the reactions there. Of course, they're going to always start out strong, right? But you have to keep making sure that if you keep agitating the tube, that they won't break up. So these two are weak. Yeah. All right, so the rest of those should be doing the same. They look strong, and then you agitate the tubes and they get weak. Yeah, so 16, tube 5 is weak, and then the next one is negative. All right, so those are negative. And those are definitely negative. Okay, so now we're going to do the cell washing and then finish off with the AHG phase. So here we go. Cell washer, here we come. All right, so we're going to open it. Look at that gorgeous thing. Right, as we put them in, we're going to make sure they spin well, okay? Gonna make sure that we agitate the tubes before we let it go. We want to make sure they're suspended so that the procedure will get all the cells washed appropriately. All right, so that's that one. Now we're doing visit number 1. We have a 24 tube rotor. Okay, so we have 2 missing here and 2 missing there. It swirls fine. We're gonna hit to go ahead and do the wash, so that means we're gonna hit start. And you've seen this before, so I'll get back to you. All right, so we're gonna go back and pick up these washed cells. All right, we're going to put them in our rack first, and then we will put them into the centrifuge, read them again, and talk about what's going on. This is visit number 1. Oops. Okay. So I will clean this out later because this needs to be wiped out. Okay. But that will be off camera. All right, let's walk this back. Put it in the centrifuge now. Oh, sorry, I'm wrong. We got to do the AHG reagent first. So we have the polyspecific anti-human globulin. Okay. So if there is a reaction with antigen and antibody, this helps to amplify that. All right, so 2 drops. Let's do it this way so you can see. 1, 2, 1, 2, 1, 2. Hope my hand's not in the way. All right. So now we can agitate and put into the centrifuge. So you get that muddy green look in the reaction tube when you know that you've agitated it well. And like we did last time, the first 2 tubes of the other visit will be in there as well. So what's happening again? It's because I'm not using 2 hands. There we go. All right, it's spinning now. Get back. All right, so the lovely buzzer went off. Now let's read them. So they might have a bigger reaction than what we had before. We'll see. Okay, so this ends up being, looks honestly weaker. Yeah. That's crazy. Look at that. You can see it. So we had in the straight before that it was 1+, but this is looking really tiny. They're both looking weak. So that's interesting. So 1 and 2 are weak. Yeah, I'm definitely not going to call these a 1. They're so small. All right. So this is 1 in 16 and 1 in 32. They're still positive, but these are all weak. And in order for us to decide if it's clinically significant, well, I mean, it's all clinically significant, but in order to do the titer reading, the highest titer that ends up being a 1+ is what you end up using as the titer level. And these are all just weak. Ridiculous. Utterly ridiculous. What the crap is going on? All right. And like it was before, it's like sub-weak, but you could still see it's positive. But I'm just going to call these two negative. I mean, it's so tiny. We're gonna, it's weak all the way throughout. It's super weak here, but they're so tiny that we'll call them 0. The first two of visit number 1.